afternoon. Thank you so much, everyone, for joining us either in person or online. Program Manager with the Office of International Programs, and this is Foundations of Global Health in conjunction with the International Orthopedic Trauma Study, Research, and Practice that places a priority on improving health and achieving equity in health for all people worldwide. Global health emphasizes transnational health issues, determinants, and solutions. Global health is a varied and rich discipline to which many healthcare providers, researchers, and faculty aspire to being professionally engaged. With our being a globally connected world, this ongoing programming through the Office of International Programs is designed to feature those in our KUMC community engaged in the field of global health. KUMC's faculty, researchers, and clinicians, our international partners, and our community partners. The series is meant to provide a platform for both presenters and participants to participate in conversations while developing foundational knowledge and exploring best practices for engagement in the discipline of global health. And our next session is on Tuesday, February 3rd, right back here. And now I will turn it over.
Thanks, Alexa. Thanks, everybody, for coming. And I really need to thank everybody, so many people in this room, for all that you've done to volunteer to help get our shipping container out to our partners in Zambia. That shipping container is going to go out on the 20th, ideally, and a lot of that would be helping the hard work of people in this room and all the students that have volunteered. So I just want to thank everybody for that. And just keep an eye on your emails, because we'll have other opportunities coming up as we get ready to send that container out. But today, we want to talk about a history of medical missions and international efforts. And I put this talk together for these stated goals. Number one, you need to understand the need for global surgery. So these are the goals for today's lecture. Understand the need for global surgery, particularly as it relates to trauma. That's what I do, and that's what we work in that field. Understand the major players in the realm of global surgery. Understand how not to behave when a guest providing medical care in another country or culture. And provide insight into global surgery that could be used to help you join or develop your own global surgical practice. You don't know it, but right now, really, if you want to develop a global surgery practice, you really kind of need to be thinking about that right now. If you think that's something you're passionate about, because where you take a job at can affect your ability to deliver global health. Fortunately, I didn't have a lecture like this when I was a medical student. And fortunately, I ended up in a place that is very amenable to be doing that type of thing. So if it's important to you, hopefully this lecture will help you out. So let's talk about the problem first, and we're just going to go back over some basics here. When we talk about trauma, it causes significant mortality, right? This is from the Global Burden of Disease study, the total number of deaths caused by injuries when compared to infection, HIV, malaria, TB, it surpasses that as of the 2016 Global Burden of Disease. And that's not changed much since then. We've gone over in other previous lectures, more recent Global Burden of Disease studies. This is about the same. Now, heart disease and cancer, we know it's responsible for killing more people. But as we've talked before, what trauma takes out is some of the youngest, most healthy, productive members of society. It's not that people that die of cancer and ischemic heart disease don't matter, but what's the difference when a mother dies versus, say, a great-grandmother? It's a different thing, right? That has a larger burden on society. And similarly, when you look at the disability caused by trauma, for every one person that dies of trauma, there's about 50 more that are significantly disabled. And extremity trauma is the leading cause of disability that we see in the world. And when you compare the disability as a result of trauma, it actually surpasses cancer, heart disease, and infection. So it's a significant problem, right? It always ends up somewhere in the top 10% of reasons of cause of death worldwide. And then furthermore, we want to talk about, or what is it that contributes to lower middle income countries experiencing greater than 90% of the trauma death and disability worldwide? So one thing in America and in Europe is when you think about trauma, we don't think of it as being necessarily this global health problem or this community health problem, because we have trauma centers that take care of it. But 90% of the deaths that occur to trauma are occurring in low to middle income countries, and there's a reason for that. So if you think about it, it causes a tremendous amount of death worldwide, and the majority of that death is occurring in these low to middle income countries. This is what we know from our study in Ethiopia and our partner hospital there, Abbott Hospital. So it's defining the problem just a little bit more. And this just segues into talking about, why global surgery is important. Well, what is trauma? Trauma is a surgical disease. It's not a disease that's treated by medicine. We don't give a pill necessarily to solve somebody who's been crushed in a car accident. And when we looked at the numbers that were coming through Abbott Hospital, that's the level 1 trauma center in Addis Ababa, Ethiopia, what we found was that 64% of the trauma cases going to that hospital were orthopedic trauma cases. Neurosurgical were about 26%, general surgical were about 7%, and other surgical cases were about 3%. So the majority of the cases that were occurring there were orthopedic trauma, which goes along with data that we know that the most common outcome of a trauma that results in a patient going to the operating room is a fracture. That's it. That's it. And this kind of mirrors that data. But what's the bottleneck to a successful traumatic injury? What is it that prevents a good outcome? And the bottleneck is this. It's a well-trained surgical team with well-equipped in an appropriately designed hospital. That's the bottleneck. And what you have in low to middle income countries is you lack all of those. You lack sufficient well-trained surgical teams. Africa is the continent of the world that has the lowest number of surgeons per people. So they don't have enough surgeons, they don't have enough equipment, and they don't have enough facilities. So that's kind of the problem. And when you have that, this is what we want. We want somebody to go through this funnel and come out on the other end and be treated well. But typically what happens is this funnel is just overflowing. And what's occurring at Abbott Hospital, the level 1 trauma center there, is they have a waiting list of over 5,000 people. It doesn't do well for them. So there's a tremendous need. We're just defining the need, right? There's a lot of people dying due to trauma. Where these people are dying due to trauma is in the poorest countries of the world. They're the bottom billion, right? And as a result of them not getting care, problems that oftentimes could be treated and then do very well because of neglect or delay, they end up being permanently disabled or they end up dying. So we have this need. Does anyone care? And that brings us to where we're at in this lecture today. And this is who cares. The devout. The devout cares. So we're going to talk a little bit about religion, and I understand that may make some of you uncomfortable. But one thing you'll see as we go through this lecture is if you want to deliver care to needy people, you're going to find there's a lot of devout people in this space. They're not necessarily Christian, and I've kind of labeled this out here. If you look at, I just have some of the major faiths of the world, and this isn't just limited to these faiths, but if you look at Christians, what are Christians taught? They're instructed to love their neighbor as themselves. And then Jesus himself gave the example of the Good Samaritan. If you read that story, the Good Samaritan was a trauma patient. That example of Jesus teaching someone to be a good neighbor was taking care of a trauma patient. The man was attacked by robbers. So for us, that's if you're a Christian and you treat trauma, that's pretty easy. With Islam, one of their 5 pillars is zakat. I hope I'm pronouncing that well. Okay, got it. Bakker said I got it. So, which is an obliged form of charity meant to relieve the suffering of the poor and indebted. In Judaism, there's this idea of tikkun olam, which it literally means repair the world. Right? They want to make the world a better place. And then in Hindu, I'm not going to pronounce this, but you can see there's this Sanskrit phrase found in Hindu text that roughly translates to the world as one family. And it was thought that this concept was what, really influenced Gandhi. with respect to his care for the poor and his nonviolence. So, and what links will the devout go to? I will tell you if you get into global health, I have a picture of the Coliseum here where, there's a lot of people that died for various reasons for things they believed very strongly. You get to meet some of the best people in the world when you go on these trips. You'll see people that turn down, jobs in large cities and in wealthy countries to go and serve the poor. I don't think there's a better definition of devout. People who care and are devout will go to great lengths to care for others. And so if you're going, one thing you'll find is if you work in this space, you're going to be working with other religious organizations. Yes.
Also, like periodically throughout this lecture, I might just interject a little thing because Dr. Hedges and I worked on some of this together.
That's right. Thank you, Taylor. And she's supposed to not let me forget important things to say. Yeah.
But that, when you're going into global health, you have to think about the cultures of others. So even if you don't end up identifying with a certain religion, that's fine, but people do, and sometimes it's their main motivator of why they act certain ways in life. And it can be so their main motivator, and then also it can be really uncomfortable for them without agreeing to it in a faithful way. And so to add that, something to think about. But.
Thank you, Taylor. And hey, Francis, can you hear me?
Yes, good. He's back now. I can hear you.
Okay, great. And I'm just going to introduce our panelists for today. This is Francis. He's the country director for Mercy Ministries in Madagascar. And we'll just be calling on Francis throughout this lecture as well. Francis, you're in Madagascar right now?
That's right, Doctor. Yeah, in Antananarivo, Madagascar.
Do you have anything you want to say at this point in the lecture?
So far so good. I mean, hi everyone. It's good to be here and to be able to learn together and share some of the daily realities and challenges we're facing in the medical world here. So looking forward to share some more of it later.
Well, great. Well, we're going to talk about, so now we're going to move into global surgery. So we talked about the need that there is in trauma. We talked about where it's primarily at, right? It's in the poorest countries of the world. We talked about who cared. So what is global surgery? Well, it's surgical care in low to middle income countries and in geographic areas of great disparity. See, global surgery really, it can be practiced here. I think probably the best example is America, is on Native American reservations where, the healthcare challenges there are great. But it's historically been done by faith-based organizations. Now, today, global surgery includes faith-based organizations, academic and humanitarian organizations. If you look here, this is just Soto Christian Hospital. It's a hospital in Ethiopia. Dwayne Anderson is the gentleman with the mustache there in the back. He's an orthopedic surgeon who kind of helped guide me along in part of this process as I got into global health. He's a remarkable man. He was recently by the American Academy of Orthopedic Surgeons given the Humanitarian of the Decade Award. So he's a pretty incredible person. And Soto does some good work. But they are admittedly they're a Christian hospital. Let's talk briefly about humanitarian organizations. There's 3 markers of distinction. Number 1, assistance beyond borders. Number 2, a belief that such transnational action was related in some way to the transcendent. And then number 3, the growing organization and governance of activities designed to protect and improve humanity. So you can see humanitarian organizations have goals that overlap with faith-based organizations. And if you think about it, your own academic institution probably has something similar along those lines. It may not have the part in there about this action that you're doing is necessarily related to the transcendent. But if you think about all these groups, faith-based organizations, academic organizations, and humanitarian organizations, we're all trying to improve humanity. And the American Red Cross is a great example of that. So, but I wanted to this is briefly put forth a timeline here to kind of talk about how did we get here, to where we're at today in terms of, delivering healthcare to people in dire need of it, such as in the poorest countries of the world. Well, if you look at the first hospitals, they started in the 4th and 5th centuries. They were started by Christians. These hospitals were started in the 4th and 5th centuries, and they were there to take care of traveling strangers who'd become sick. And then, after that, as these kind of took hold in the Roman Empire, the Jesuits in the 16th century introduced the term missions, referring to the expansion of the faith, including medical care. Now, that's a lot different type of medical care in the 16th century. That was back in the humoral theory of disease, when you can imagine somebody walking into another country and saying, the reason you're sick is because you've got an imbalance between your black bile and your yellow bile. If you read about the early accounts of these mission trips, it said that a lot of these cultures opted to not seek care from them. So I'm not sure it was so successful, but tropical medicine took off. And once, we figured out, the causes of malaria and things like that, we really started, having an impact in terms of healthcare, and it started to be recognized and accepted more. The Red Cross was developed back in the 1860s after some wars in Europe, and the number of injured were just so great. It wasn't something that could be cared for by any one church. It needed something much larger. And then after World War I, the League of Nations Health Organization, later termed the WHO, was developed. In the 20th century, you see some formalized Muslim humanitarian organizations developed, and then Doctors Without Borders. That came out of kind of weird, but they were developed in 1971. And finally, the American College of Surgeons begins to focus on global health in the 1980s. So if you think about that, this is really new. And you are on the cutting edge of something. I just can't tell you. When I was in medical school, I didn't recognize the things I was on the cutting edge of, but you are on the cutting edge of something. And particularly in a world where now with renewable energy, where you can take a hospital and you can put it almost anywhere because you can provide the energy for it, as long as you have a source of water by solar or wind. I mean, there's just all these possibilities that can now happen in global health that couldn't happen necessarily when I was where you're at. What are some examples of success? Well, the Emperor Julian even wrote about the success of the Christian hospitals, and he lamented how his own government wasn't caring for the poor, and how the Christian, their faith was growing just by their caring for the needy people. In addition, if you look in terms of the discovery of certain diseases, such as sleeping sickness and things like this, or mission hospitals that help contribute to understanding that. A good modern example today is the cure hospitals. The interesting thing about cure hospitals is cure hospitals are hospitals that provide pediatric care for children, typically with orthopedic deformities. But the reason why those hospitals were founded was because the founder was getting his cases bumped all the time by trauma. He said there was too much trauma. So just an interesting point. Making the point, we need hospitals for trauma. What about secular humanitarian global health success? Most of these are in the realm of infectious disease, but look at this: 1980 smallpox eradication, 1983 HIV was discovered, treatments discovered and implemented, 2014 the Ebola outbreak was successful international response, and 2021 this malaria vaccine for children. So now when you talk about secular successes for surgical type problems, you can see there's Operation Smile Train, and Mercy Ships. But do you think those things can be used to treat a trauma epidemic? The answer is no. You can put a Band-Aid on certain problems, but it's not solving the problem here. And again, that's just to kind of get at it. That's the point of this lecture is if we're going to have an impact on something like the trauma epidemic, it's going to take lots of different types of groups working together. Faith-based organizations, humanitarian organizations, academic organizations. So we're just going to briefly touch on how much time we got. I want to make sure we're not. Okay. To tell you where we're at, I just want you to think about something. You saw all those successes that were listed in terms of infectious diseases. There is no surgical equivalent to a mosquito net or a vaccination campaign, right? So although, and this comes from an article by Paul Carpenter, who started Partners in Health, where he said where he says surgery is the neglected stepchild of global health. And there's a number of reasons for it, but one of them is just the sheer complexity of delivering good surgical care. But we're getting to a point where I think thoughtful, caring people can have an answer for this, right? We're here to try and help solve this problem. But up until now, major financiers of public health don't regard surgical disease as a priority. Communicable diseases, it's kind of easy to sell, particularly when you can tell, Westerners, it's easier to treat this disease in Africa before it gets to America. You know what? That works. That works. But surgical disease, particularly trauma, that's not necessarily communicable. That's more of an argument of we need to care for our neighbor. And that's a harder thing to sell. So briefly, I just have some things listed here in terms of the amount of surgical care that needs to occur overseas. 5 billion people don't have access to safe and affordable surgical care worldwide. In low to middle income countries, approximately 90% of people lack access to basic surgical care. Of the 313 million surgical procedures done each year, only 6% occur in the poorest countries of the world, right? This is why 90% of the trauma deaths that occur in the world occur in low to middle income countries. Trauma is a surgical disease. It's that simple. We need about 143 million additional procedures in low to middle income countries each year to prevent tremendous amounts of disability. People have thought through this. There have been some really good thoughts put in this in terms of the amount of surgeons we need per capita, like in each country, what types of hospitals we need. One of the major reasons, and it's not in this talk, but one of the major reasons people die due to lack of surgical care is childbirth. It's one of the major causes. So just having the ability to do a cesarean section can save lots of lives. So not all global health initiatives address the need for healthcare the same way. And a lot of these you see are Band-Aids. A lot of these overlap. There's different types of medical missions, short-term mission trips, about a week or two, where you go in and do something. Longer term, which may last a year, where you're there to teach, build up infrastructure, and treat. Surgical missions, which are focused on just particularly one thing, like doing cleft, lip, and palate surgery. Dental missions. Emergency response missions, where there's a particular earthquake, like in Haiti or something, and you have a lot of people go there to try and help. Public health missions. Educational and training missions, mental health missions, it kind of goes on. But again, you can see these are the things that are occurring, but they're not a sustainable solution. Which brings us to this. What are we doing here? Speak up, yeah.
I was also just going to add, so when we were looking at that framework for all the different types, so one thing to note is that that's kind of like a simplified framework. Quite a bit of it, they're actually overlapping. For instance, we as like ATI, we're not like a faith-based organization because we're academic-based. However, we can work with faith-based organizations. It's okay. And it's also important to think about when you're thinking about like the history of how these all came to be. Like quite a bit of it is based in colonialism. Like even with tropical medicine, it's like outsiders ended up deciding like, okay, who ends up being important enough to care for? And that's why certain diseases were treated. Whereas now the model is much more, okay, let's go to local leadership, figure out who should we end up going to, what are people in these specific areas actually wanting, and that's been ATI's goal and part of our primary mission, which Dr. Headings.
It's true. It's like our biggest part. Yes, Dr. Toby.
I'm going to have to leave. I want to say Archie Headings is the real deal. He has devoted his life to this, and he has done great things. And one of the things that he does is he educates his the indigenous doctors, the patient, the people who are actually going to provide care year round. And I think that that's one thing that is sustainable. when you train someone at a high level, we're not talking about, you know, putting Band-Aids on, but being able to do trauma surgery and they become excellent, you leave a legacy that lasts, and then they train other people. And I think that's one of the best things that you can do. And someone who has done that so well is Archie Henry. So congratulations to everything that you've done about here. It's been wonderful.
Thank you, Dr. Toby. Dr. Toby taught me to be a surgeon, by the way. So there's no better person to talk about teaching surgeons and having a lasting impact than Dr. Toby. But that's such a good point, Taylor, because our biggest partner right now is the Ethiopian Orthodox Church in Kansas City, which has raised thousands of dollars to help out hospitals overseas. They have a vested interest. Some of them have been treated when they were in Ethiopia in the trauma center that we work at. So, but it's a great example. They don't do healthcare, but they care. And if you, they've given more money than KU's given in terms of like people at KU. Now, KU's given a lot of resources, but it's a good example of how we're working with a faith-based organization. So, okay, well, let's talk briefly. How much time? I want to make sure. Let's talk about the 7 sins of international health. I just want to go through this really quickly because I thought this would be the best lecture to cover this in. I'm going to give you some examples of in my own life and something embarrassing I'll show you. So these are the 7 sins of international health. And these were described in an article by a general named Welling, by a person named Welling. Here they are. Number 1, don't leave a mess. So it's one of the easiest ways to do that is taking a bunch of equipment that they may not necessarily use or sending them a bunch of equipment that they won't necessarily use. And then they have to find a way to dispose of it. I sent a 40-foot long shipping container to one of my first international health partners in Romania. I didn't realize it, but it was full of nothing they wanted. And so when it got there, they refused to open it up. They just said it was a bunch of junk, honestly. It was a bunch of expired goods. I think if you're going, so if you wouldn't treat yourself or your family member a certain way, don't expect to treat a poor person in another country that way. And it was a really good point to me of them saying, our patients matter as much as your patients. Would you use this in America? And answer no. Then why would you send it to us? And it was a learning curve for me. Of course, I didn't realize that was the way that this particular charitable organization worked. They said, we'll send all this medical equipment there, but a lot of it was expired. So it was a big mess. I just can't tell you what a mess it was. So don't do that. Failing to match technology to local needs and abilities. If you're going to go in a place and do a complex surgery, make sure that the surgeons there can follow it. One of the people we work with in ATI is a man by the name of Adam Goodyear, and he was on a mission trip where they did a total hip. They left. The people that were at the hospital could not manage the total hip. The patient dislocated. They remained with the dislocated hip for a year until they returned the next year. And so that's just a miserable experience for that patient and everybody involved. Failing to cooperate for non-governmental organizations to cooperate and help each other and accept help from military organizations. I'll just tell you, if you find out before you go there what NGOs are in the area and you can work with them, it will have a synergistic effect on your impact. Failing to have a follow-up plan, I've seen that. I just can't. The very first mission group that I worked with, we would go in, we would operate, and we would leave, and there was no follow-up plan. The next year we came back. I will never forget hearing the leader of the organization just really kind of getting critiqued quite critically by one of the healthcare providers in the area who wasn't able to follow all of his patients. He just didn't know the surgery that these people were doing. Allowing politics, training, and other distracting goals to trump service. This happened to me inadvertently once. When you're an American surgeon, you go somewhere, you may not realize it, but people are going to seek you out just because they think you're the best, just because you're an American. And one of the mission trips I went on when I got there, it was all the wealthiest people of the town that were lined up to see me. I didn't realize it, and they were paying cash too, so it worked out great for the facility I was at. but that's not why I went there. I had a lot of soul searching after that time off. So it's just things you need to think about. Things you need to think about in advance. It's like an agreement with the place you're going. What am I doing when I arrive? And going where we're needed. Don't go where you're not wanted. I saw one CRNA get kicked out of a hospital where he was, trying to take over and do things that he shouldn't have been doing. And then finally doing the right thing for the wrong reason. And there's this Onion article here. And I think you all may have seen something similar to this, but 6-day visit to rural Africa, African village completely changes woman's Facebook profile picture, right? This isn't why we're doing international health. So I'm going to show you something. This is very embarrassing. The sound's going to be up. But I just don't do this. And I think if there's anything good about this, it shows the humanity of me. I don't want to give the perception that I'm perfect. So we're going to go through this. How much time we got? We're going to go through this really quick. So here I am driving into the hospital.
The pictures I took of this road yesterday, I took pictures, and they're really beautiful. And I didn't realize it until I looked at the picture last night.
Okay, let's do this again. I just want you to see some things. Yeah, there's this look.
The pictures I took of this road yesterday,
There's that look.
and they're really beautiful. And I didn't realize it until I looked at the picture last night.
Let's watch this. This gentleman's minding his own business over here with his hand on his neck. I start getting yelled at. Here. I was just videoing people. It was wrong, it was just wrong. I don't know how to even put into words exactly what wasn't right about this, but there was something about this that everybody knew. I was not respecting the dignity of these people. I just don't know how else to say it. I can talk about it all day, but I was not respecting their dignity. And boy, did they see it. That's not what I want to do. I think there's an innocence to this in that when you do see people living like this, and particularly when you can see children playing and how happy they are, and there's something intriguing about it. It's true. But people don't know the intent of your heart. If that's really what it is, fine, that's great. But you videoing people just like this, particularly when they see an American and they know they're poor. If there's one thing you'll realize when you travel overseas, and everybody has a cell phone now, everybody's aware of how poor they are. They don't want to be shown, on your Facebook page as a very poor person. They do not. They have dignity and need to be treated with dignity. So just be a good guest, be aware of this. Now to introduce Francis. Francis, can you hear me? Thank you, Dr. Toby.
Yep. Yes, doctor, I can hear you.
Okay,
Hello,
I'm going to
everyone.
play your video just as an introduction, then we'll segue into you talking about your work.
Sure, that's good.
Hello everyone, this is Francis, all the way from the beautiful island of Nosikomba, that's off the northwest coast of Madagascar. We've been here with the Island Reach medical vessel for the last couple of days. We've been reaching out to this community, and there are thousands of villages like this around Madagascar who are so desperate for medical care, dental care. Just imagine, in Madagascar, you get one dentist for a population of 150,000 people. just to give you an idea. So the need is big, but also as big is the need to hear the good news, the liberating good news of Jesus Christ. So Island Reach is such a blessing. It's a dream coming true. We've been praying for more than 10 years for this beautiful gift, this beautiful instrument to come and serve the people of Madagascar and the work of God here. And yesterday was the first time for that lady to jump on board, to receive treatment, and things like that. It's just making a tremendous difference.
Za zany docteur Léon Sayon Marie-Christine, na avy amin'ny ity sambo ity za, avy amin'ny alalan'le ONG Merci Monsieur. Izy ity zany mitovy cabinet dentaire fa sur bateau. Dia afaka manao extraction, afaka magnano détartrage. Extraction zay efa nagnano sur bateau et sur l'île satria zio ty zay efa 3 jours zegny zay taty. Ary a Madagascar soin dentaire mbola lafo be. Ka fa misy cadeau ndra karaha io magnantogna nareo.
Ny anarako edy Mobary, président fokontany eto ampangoriagna nosy fomba. Izy koa fitsapagna nosy be tegna mandany volanay. Ny karaha malaka anao mandeha agny, avy agny koa anao mba magnefa l'hôpital mividy hody, tsy vaharaka ny aty ambanivolo karaha zay. Aty tsisy tomobily, tsisy bajaj fa ny raha momban-drano amy karama 10 000 ariary, magnano 10 000 ariary amy hody. Ny karama koa anao mitokitoky manonga agny, mividy hody, tsy dia mahafinaritra aminay aty loatra raha. Ravoravo zay ny fahaviandreo eto. Ireo docteur maromaro mitsabo zay eto. Tegna mahafapo zahay. Tsy dia mividy hody eky zahay, tsy mandeha nosy be fa ny fitsabogna mahafinaritra nataondreo eto amin'ny ampangoriagna.
Anarako Jamaro zany. Toerana viako boka Ambilibe. Fa za fo miasa eto magnano maso. Nataoko mandeha magnadoso nify. Misy mandeha nosy be, mandeha magnapoaka nify. Eto misy fa matetiky magnano vakansy andafy zegny vazaha magnadoso nify eto. Zegny kofa tsy eo izy mandeha nosy be fa magnapoaka nify. Lafo izy magnadoso fa za tsara magnadoso amako nagnadoso niany.
Hi, my name is Kenny and I am from Mauritius, and I just want to tell you about the boat, The Island Reach, that we've been collaborating together. We call for your support for those of you who have experiences with medical care.
Dentists, eye care specialists, you name it, nurses, please come join us to make a difference in Madagascar. And even children ministry, anyone who can come and just have an impact here. We also need financial support. We have to put fuel in the boat to run it, join hands and partner with us. So thank you so much, guys. And we look forward to hear from you in partnering together.
Hey, Francis.
Yes, doctor.
That's pretty amazing work you're doing.
Thank you. Thank you. It's good to see the progress, and yeah, we encourage.
When it comes to the medical needs of the population of Madagascar, how great are they? And you were, by the way, just so everybody knows, Francis came and worked in our hospital, so he's seen it. So if you could just compare the medical care that people get here at KU and what people get in Madagascar, how would you describe that?
Wow. Well, I saw the infrastructure, the possibilities that are there in KU, and I say this is a different planet. Like, there's no way to compare, what people have here to what is existing there in the US. In Madagascar, most of the people, we're talking about 70% of the population, 32 million people, most of them have to walk through the forest for a whole day before they can access any medical facility. And we're now using this boat because, it's an island, and many villages that are only accessible by the sea, by the ocean, sorry. So yeah, there's really big challenges in regards to the access to healthcare.
You know, one thing you told me that I thought was really telling in terms of the trauma care there was, you know, what you witnessed one day when you saw some children struck by a car. Do you mind talking about that story just a little bit?
Sure. That was just shortly before Christmas, actually, in Antananarivo, the capital city. So there was a new road that they just opened, you know, to in a certain part of the town, and then there are a few schools there, and they actually didn't think of putting any, you know, special place where kids can cross the road there. And people just drive, you know, there's no speed limit or a traffic light or whatever. So there was a group of kids coming back from schools. I think there was like 6 or 7 of them together, and they were trying to cross the road. And I was watching the, I mean, I was also driving past, so I could kind of see what was happening. They looked and there wasn't a car, so they started, they engaged to cross the road, but then this driver was going so fast. So like in a matter of seconds, he just, you know, drove through them. And you can imagine it was just such a mess. And of course, we had to, you know, stop and try and help. And I was carrying some kids to the hospital. And I mean, thank God I was in town, in the capital city, so you could. I think we drove for about 20 minutes and we could get them to a hospital. But imagine this is happening in places where the nearest hospital is like hundreds of kilometers away. So before you get there, I mean, they won't even make it. So, and this is happening, you know, on a daily basis, as you know, Dr. Fabrice was saying the other day, for people, it becomes even normal, you know, when we're starting to talk about this trauma and how this many deaths could be actually prevented. But people are like, you know, it's not possible. This is our daily life, and they just die of things that you could avoid, you know.
And one thing you said about that that was really telling to me was when you stopped at the scene, a lot of the people that were there just had the opinion there's nothing we could do for these children. And you had to convince them that they should be taken to the hospital.
Yeah, I was even, you know, shocked because I got out of the car and I was like, okay, let's get them to the hospital. And some people are just standing there, you know, kind of watching, and some are even surprised that we want to do something. It's like they get to a point of you know, just give up, or how you say that word, like uh, um, you know, when you feel like, okay, what can we do, type of thing. So we have to actually, you know, teach the people like, no, we can't just accept like a fatality like this. You know, you can do something. It's possible to do something. Let's find a hospital. And you know, and that's again, this is happening in the capital city. But imagine places, and Madagascar is mostly rural. I mean, there are places where, you know, they know there's no hospital. So it's like people come to a point where they get used to fatality, to just saying, okay, you know, this is our life. Somehow we've been used to this. We are forgotten. There's no access to medical care, and which is quite sad because it shouldn't be the case.
Yeah, it's not that they don't want to help the children, but it's just that medical care is so limited. The attitude is there's really nothing they can do. That's my impression of what you're saying.
That's right. That's right. Yeah.
Well, I want to make sure we give the students a chance to ask a question. Does anybody have questions for Francis about his work that he does in Madagascar?
Hi, Francis. It's Leland. I was wondering, like, for students in particular, as we're thinking about doing like global medical missions, most likely if you're at this talk, what skills, like especially non-clinical skills, do you think we should start working on now to help us?
Could you hear her, Francis?
I'm sorry, I couldn't hear that one. It's quite far. Could you please repeat for me?
She said, what skills could for students who are interested in doing work like you're doing in Madagascar, what skills could they work on?
That's a very good question. You know, like, of course, as we heard from the Dr. Hedding's presentation just now, 64% of this trauma are orthopedic. So I can imagine, surgery, being a surgeon could be a very big help. But then, also, just being a nurse, dentist. This video, I mean, the Island Reach, we're talking mostly about dental needs. In Madagascar, there is one dentist for this many hundred thousand of people. So also even eye care.
She asked
Actually, the
also
health.
about non-clinical, like what non-clinical skills can the students be working on as well? And
Oh,
hello,
non-clinical.
Fabrice. Yeah, hi.
Yes. It's good to hear from you, Kim. um, there are we spoke about the need for awareness, raising awareness now, just training, teaching people. That's also a big part of it. Like just coming alongside and showing people that actually it's possible to live another way, like to not just accept the fatality, so you could I mentioned children now, educating the kids, sensibilization, things like that. It can also make a difference. Even putting together, short clips, videos, whatever, just to teach the people, to educate, that could also make a big impact.
And Dr. Fabrice, Fabrice, can I add something to that? I would say for people who are interested in like maybe a career or exploring global health and international educational engagement, one of the things that you're doing right now, attending Foundations of Global Health, that will help prepare you, because important is developing the right attitude and the right approach. So Dr. Heddings models this in his programming and his collaborations. So seeing how our faculty, how they develop relationships and collaborations, their humility, their respect, their acknowledgement of expertise in other countries. How do you make connections? How do you utilize local people to set the they need to be goal setting. It has to be their goals, their objectives that together you support. So, spending time to understand how this is done, it takes time. It's relationship building. It's trust. It's built on respect. And then reading. There's a lot, Dr. Heddings mentioned Paul Farmer. There's so much written today about how to engage in an equitable way where that's mutually beneficial. So reading about how you can build those collaborations that are positive and sustainable. And also going to websites like Child Family Health International. They have great resources about fair trade learning and fair trade partnerships. There's a lot of information about what not to do as well as what to do. So kind of building on what Dr. Heddings was saying, what to avoid in your interactions, down to something so little as taking a photo. We often say, or I've heard people say, well, I asked permission. Well, that doesn't make it okay. And we all know what it's like to be in an awkward situation where someone asks us if it's okay. So just imagine yourself at the park with your child or your sibling, and a stranger comes up and asks if they could take a picture of you because they love your costume. Your clothes look so different than the clothes they wear. It would just be awkward for you. So just remembering again what Dr. Heading said, if you wouldn't use it for your patients, you wouldn't do it, to your patients or your family, then it isn't appropriate, even if you've asked permission.
100%, Kim. Hey, Francis, on that part of education, you told me some really interesting stories about just educating people in the villages of Madagascar can have a profound impact on health. I don't know if you can talk about it, but I know there was one example of, you said in some villages there was this belief that men had a menstrual cycle because so many people had schistosomiasis, and also I think you said something. Yeah, Can you talk about, because I think that really hits on the point of just educating people.
Yeah, sure,
Can you
sure.
talk
I
about
mean,
the challenges you have there just in educating people about their health?
I think education is really a big part of it. And because Madagascar is also a place where people are so attached to their, traditions, ancestral traditions, things like people have been doing over decades and many, many years. So you don't ask questions. You just do it because it's been done like that. And there's that example of man, it was actually related to the water. There's many places where there are waterborne diseases. That was one of the cases where men, were having blood in their urine. There's also another village where we've been, where most of the kids in the village had diarrhea, very bad diarrhea, even some adults, and they would think, okay, this was a curse from the ancestors, and they were trying to do sacrifices to appease the ancestors. And well, we actually realized, because we spent few days there with them in the village, and we realized people were drinking from the river that was just flowing near the village. But then the thing is, most people, there were no latrine in that village, no toilet. And so people, ease themselves in the bush nearby. But when it rains, because it was the village is on a high hill, then when it rains, the water flows down to the river, and then the river gets contaminated, and that's where they're drinking for. So with the doctor, we thought, you know what, we need to have a meeting. We gathered all the people with the chief of the village, and we, through like a skit, we could show them actually, when you are doing your thing in the bush, it's not staying there. When it rains, this is what's happening. It all flows back to the river where you come in to drink. So we started talking about microbes and how, water gets infected, and, all the bacteria in the move to the stomach and cause diarrhea. And slowly they start to realize, actually, we are damaging our own health by doing this. So the chief of the village, with his committee, at some point, they stood and said, we need to make a decision. And they discussed between themselves, and they came up and said, well, we'll take 1 month. And after 1 month, every family, during 1 month, every family must, create their own latrine, dig a hole behind your house and make a plan. And after 1 month, if a family doesn't have a latrine, we will give them a fine. So we left and came back after 1 month, and guess what? All the families literally had their own latrine, and diarrhea was no longer a problem. The kids were much healthier, and you could see that just because they didn't know, and we told them, well, that was not from your ancestors, but it was just like, behavior and being health conscious. So things like that, you can see the impact of education and teaching people makes a difference.
I love that story. Does anybody have questions for Francis? I don't want to ask him. I have questions, but I want people to, yeah. Annie.
And who are the providers on the boat? Like, how are they?
Yeah.
Yeah.
Annie wants to know who are the providers on the boat? How do you get the providers on the boat?
By providers, you mean like the health personnel on the boat?
Yes.
Yeah, so we have only two Malagasy, local doctors, but then mostly we have like volunteers who come and dentists from outside, nurses, eye care professional who want to, volunteer their time. They say, okay, I have 1 week or 2 weeks to give. Then, yeah, we welcome them on board the boat that we can accommodate 15 people easily. There are rooms, toilets, kitchen. The boat is fully equipped. So yeah, they could stay on board and then we go around. We have like 2 local people, but then we welcome outside volunteers to come and help us well.
Can you follow that up with like after they end up finishing care in a certain area?
Yeah.
How do they like work on follow-up?
So how do you do, Taylor wants to know how you do follow-up. So after you provide care, then how do you do your follow-up care of those people?
So we do it in 2 ways. We do have a team that goes back to the villages, say a week after the boat has been there. We have a team of there's medical and some are non-medical. They will go back to the village to check on the people and see how they're doing and see if they need more care. And then generally after 1 month, we'll try and visit again with the boat if there's need for more medical intervention. But yeah, we do have a team that does the follow-up.
And what's your biggest challenge, you think, Francis, to delivering care? What's your biggest challenge?
Some of the biggest challenges we face is actually to get the people, because you could imagine now that they don't have the access to healthcare is so limited. You could imagine that people will be so desperate. They actually are, but fear is actually a big some will be afraid that they might because most people never have been to a hospital. Can you imagine? Some are even scared to go to a doctor. So we would even sometimes send an advanced team to tell them, okay, the boat is coming on this day and this is the care we'll be offering, and reassure them, like just remove the fear, the barrier, because some will just run and hide in the bush. But so this is one blockage that we try to deal with to prepare them. And then of course for the boat now we need medicines. We also need to put fuel in to go to different places. So I think logistics, I would say logistics and preparation, education are some of the main challenges that we face in these operations.
Wow, I learned so much every time I talk to you. I wouldn't have guessed, it's just because it's such a different culture. I wouldn't have guessed that the main problem is fear. It's so interesting to me, but it's such a good point, I guess.
It is, especially for Madagascar. As being an island, when you are in a country with where it's more open, where people see more visitors, it's different. But here, I'm telling you, there are places where they haven't seen any foreigner. So just that, people live in fear. The road access is also, a bit isolation. Actually, isolation. That's the main thing. That's why people will feel so, neglected. They feel like they've been forgotten. They feel like nobody cares. So things like that, to come and say, no, actually, there are people who care. They will come, they will provide care for you guys. And you realize once again, it's not just us coming there and bringing medical care, but again, how do we build relationship? How do we create meaningful connections? How do we help these people regain hope in life, in the people, in God? And that's, for me, that's the most beautiful part of it, beyond the medical, but it's really the heart and the connection to the people.
Yeah, I know that is a big part of you. I mean, you're just an incredibly impressive individual, and I don't know if you would mind just sharing a little bit of your story, because you're not originally from Madagascar, but do you mind just telling everybody a little bit about yourself, how you got into this ministry, and maybe just speak about some of the most rewarding things in it for you?
Sure. I could share a little bit about that. Originally, I come from Benin, West Africa. It's a long story, but I think I could say then I went, to do some studies in Switzerland. Beautiful country, nice place. And when I was there, I've always been a believer, but I wasn't really, into like going to far places and serve like missions. But when I was there in Switzerland, I had an encounter with an old gentleman who were going to Madagascar once a year. And he actually invited me to join with him. He was part of a group called YWAM, Youth with a Mission, that I later joined. But yeah, I did that. That's like 20 years ago now. I did a short mission trip with this guy, and he had a doctor with him, like it was kind of a medical mission actually. So we came down to Madagascar and saw the need here. I've been to many, places, many countries in Africa, but I would say Madagascar is very special. And what I saw here really stayed with me. And even when I went back to Switzerland, I had planned to stay there, but I thought, you know what? I think it's also should I say, the type of a calling, like in the heart. In my language, there is a say that there is no such a tree that eats its own fruit. It's like you bear fruit for others. Like for me, making yourself useful to humanity, to others, it's such a great thing. It really makes an impact. And I mean, Jesus said that what is the greatest command is to love God and to love others, to love your neighbor. So I thought, if I could stay in Switzerland and have a good life, and I mean, many African young people want to do that, and then you could understand where they're coming from. But for me, I thought like actually it will make my life will make more sense going back and just trying to be useful for others, and creating more opportunities and possibilities for others. And the beautiful thing is that I didn't do it just myself. I joined a team that was already there, and together, we started this work. And today I look back and I can see all the impact that we could do together. And this is so rewarding, because of course you come with the heart and idea that, okay, I'm going to help, I'm going to do this. But truth is, you are actually transformed yourself. I am being transformed every day. I'm being impacted myself by what I see, by what I learn, and by the people that I meet. It's making such a huge impact in my life and my family's life now. So yeah, some of what I can say,
Does anybody else have questions for Francis?
I feel like I always do. So.
No, that's good. Taylor, what is it?
I mean, I'm kind of wondering, because he's worked with so many different types of leaders. And so in terms of him not being a medical person working with medical personnel, like what are different traits that he finds like easier to work with people when they're thinking global?
Did you hear that question? That's a great question.
I'm sorry, I didn't. Could you please repeat for me, Doctor?
Okay, here it is. Taylor says she knows she knows that you work with a lot of different health professionals. And in the process of working with different health professionals or other people over the years, what are traits that you see in them and sort of that makes them easier to work with?
Well, that's a great question. I think, each and every person being health professional, or I myself, I'm not like directly a medical person, but I see these people, are really, really great human beings. I mean, you've met Dr. Fabrice, and for me, this is like one of the amazing guys. Like, he was trained outside of Madagascar. He had great opportunities to go work in other places, but then he chose to come back. So, things like that, it really impacts me. And the beauty of it is, like, there are those people with, medical trainings, the medical professional, but there are also, people who just come and want to be with the children. I've got a friend here, all he does is take a soccer ball, football, and, walk through the village. And I mean, 10 minutes, all the children of the village are with him. And, they are playing. Then at some point he will pause and start passing across messages related to, health, hygiene, nutrition, all of that. He's doing that through, soccer. So it's really about, okay, how do we want to make an impact with whatever skills that we have? Medical is great. It's really, in a place like Madagascar. But then if you don't have that and you have other skills, still you can make an impact here. So I see in each and every person the potential and the ability to have an impact with whatever skills they have.
Boy, that's really good. And that's like, it seems like the total package too. I mean, you want healthcare providers, but you need that guy who's playing soccer with the kids. Yeah, I get that. It's just kind of like it opens the door. So, well, I just want to. So I just have to ask this because I'm sure Taylan, I don't know if she was trying to get at it, but I just have to know. Have you had any negative experience with providers or people? And if so, what was that? And have you seen ugly Americans? I'm just curious, and because that's part of the talk is, we want to avoid, causing problems. Have you seen that? And if so, do you have any, recommendations or things to avoid or behaviors to avoid?
Come on, doctor. There is no ugly American. All the Americans are beautiful and very nice. No, well, to be honest, some of these guys, we do meet sometimes. People will come with their, how can I put that? Like, they come and, like, the attitude is more like, okay, I've got it all together. I come and I do this, and they all over the show and do their thing and go, and they don't even care about other locals, what was happening there, how can we, join together, especially follow-up. I mean, follow-up is a very big part of any medical mission. But then, I've met people who even came and said, okay, we're going to that place. And I ask, okay, how do you choose to go to that particular area? And they're like, well, we've just heard the name and it sounds like a nice name, just like that. And I'm like, well, but there's nothing there, or maybe how do you do follow up there? But that was not a major concern for them. So I think things like that are more damageable. The best really is to always partner with some local already existing ongoing work and see how to come alongside them, how to supply, reinforce them, join hands. That is always more beautiful than just going as a lone ranger and I know what I want to do. And unfortunately, you do meet people like that. But yeah, thank God it's not too many. But yeah, we do have met people like that.
Oh, that's really good to hear. We need to hear that. Any other questions? I could talk to you so long, Francis. I could talk to you so long. I just have absolutely loved this.
Thank you.
I have not read that document that you sent. I want to sit down and look over it this weekend. And we'll get things together, you know, to kind of work on our initiative that we're working with you and Madagascar on. And I would just say, please help guide us. You know, we want to be a help to you. You're helping us. And we want to be a help to you, and whatever needs you have, particularly from an orthopedic trauma perspective, we want to be there to help you. Just find a way to deliver the best care you possibly can for those type of orthopedic trauma conditions. But thank you so much.
Oh, you're most welcome. It's really a privilege for me to be able to join in and share a little bit with you guys. And I'm really, really so I'm encouraged and inspired by the work you're doing in Ethiopia and Zambia, and to see this I'm starting this collaboration with KU, and yeah, looking forward really for more things we can do together, and hopefully see you in Madagascar also soon.
That's the plan. Yeah.
That's good.
We hope to be there in summer if that works out.
Sure. That would be awesome. That would be awesome. We'll work around it.
All right. Thank you so much, Francis.